Hello everybody, welcome to my YouTube channel NurseEd Simplified. Today we will discuss about one of the most heating topics and among the nursing students. Before that, if you do not subscribe or like my channel, please do that and support it. So we will discuss about COPD or Chronic Obstructive Pulmonary Disease. In this chapter, we will discuss about the introduction, pathology, about COPD, the sign and symptoms, diagnosis, treatment. What is COPD? So, as you can see, it is a chronic obstructive. The word chronic is there. It is obstructive. Pulmonary, which means lungs, is a lung disease characterized by chronic obstruction of lung airflow that interferes with normal breathing and is not completely reversible. If you see the anatomy of the lungs, you can see we have the larynx. This is called the respiratory canal. So when we talk about the respiratory canal, it starts with the epiglottis and ends with your bronchus or bronchioles. Okay, so we have the trachea, which is divided when it enters your both lungs. It divides into bronchus, the left and the right, and from there it divides into bronchioles, and we have the air sacs, which are called alveoli. Okay, now what are the etiology or the risk factors? Here also the etiology and risk factors will be the same. Exposure to smoke particles, that is tobacco smoking, indoor air pollution from heating and cooking from the biomass which is poorly ventilated, and occupational dust if you are exposed, if there is outdoor air pollution. Other than that, there is genetic predisposition also. If you have a genetic history or a predisposition to alpha-1 antitrypsin deficiency, if there is airway hyperresponsiveness, maybe due to some allergies, lung growth and development, if it is subdued or if it is suboptimal, oxidative stress, gender, age, we see that COPD is more relevant in male than in females, and also the age factor, respiratory infections, socioeconomic status, and infections. If you have any infections, which may be bacterial, which may be viral, may also affect your lung pathology. When we talk about the pathophysiology, it always starts with the etiological factors. Whatever it be, there's a chronic inflammation in the airways and the lung tissue due to toxic gases. That leads to narrowing of the airway that takes place, which leads to destruction of the lung parenchyma. That further brings changes in the pulmonary vessels of vasculature, which includes thickening of the vessels, collagen deposit, and destruction of the capillary, which leads to, because of this destruction of the pulmonary vasculature and thickening of the vessels, the capillaries, they start being destroyed, and that releases lots of fluid around, and that leads to mucus hypersecretion. And when there's mucus hypersecretion, that leads to chronic cough and finally sputum production. Symptoms: the patient will come to you is breathlessness, usually persistent, progressive, which worsens with exercise and stress, chronic cough, which is productive, wheezing, sleep apnea, hemoptysis. The signs are tachypnea, prolonged forced expiratory time more than 5 seconds, pursed lip breathing on expiration you can see, use of accessory muscles of respiration, tar-stained fingers, flapping tremors, weight loss, barrel-shaped chest. This is one of the very important question in the what do you call that, in the NCLEX or in the MCQs, whichever MCQs you attend. Barrel-shaped chest is commonly seen in COPD. Next, we come across something called the Hoover sign also. This is also one of the typical features of your COPD. And what does that mean? It is basically, it is like a weakness of the lower limbs, and basically it is this is you done by the, it is a neurological test that is done by the physician. One is related to leg paralysis, one is related to pulmonary function. So one that is related to the pulmonary function, what we observe the patient during the normal breathing, and when there is a paradoxical inward movement of the lower lateral rib cage, or what we call the suprasternal supraclavicular fossas, during inspiration, we call it positive Hoover sign. And anxiety and depression, of course. COPD, earlier COPD was divided into three: asthma, chronic bronchitis, and emphysema. Where that is, COPD is a combination of these three. But now, because asthma is also partially reversible, we have evolved into this concept that COPD now involves chronic bronchitis and emphysema. What is chronic bronchitis? Chronic bronchitis is chronic inflammation of the lower respiratory tract, characterized by excessive mucus secretion, cough, and dyspnea. Along with that, there is recurrent infection of the lower respiratory tract. On the other hand, emphysema is a complex lung disease where there is damage to the alveoli already, and you will see the patient coming with recurrent infection of the lower respiratory tract. Diagnosis is done by history collection, past medical history, family history. Along with that, we have some pulmonary function test to determine the disease severity, confirm the diagnosis, and evaluate the progress. That is called PFT. We call it PFT. And spirometry, you will hear this, we evaluate the airflow obstruction. Now, there are some parameters. Now, if we see that the forced ejection velocity, FEV, if that we decide the level of positive or not, we do a spirometry, and we realize that the findings, the FEV to the forced expiratory volume, we see compared to the forced vital capacity ratio. So in that, when we see the difference, what is FEV1? FEV1 is a volume of air that can be forcefully exhaled in the first second of a forceful exhalation. What is vital capacity? It is the total amount of air that can be fully exhaled. So there is a difference. So if this ratio is said to be 0.7 or 70, it should be above 70%. Now, if you have something called a COPD or some chronic obstructive pulmonary disease, in that case, it will be less than the 70% or 0.70. Okay, and then that will tell you basically that the patient is having COPD. Next, we come to the ABGs. Now, ABG, we know it always decides the baseline exchange status. X-ray. X-ray was a signs of hyperinflation like a flattened diaphragm and an increase in the volume of the retrosternal retrosternal air space, hyperfluency of the lungs, lucency of the lungs, and rapid tapering of the vasculature. They all mean, and a typical barrel chest will tell you that the patient is a typical example of COPD. Now we move on to the treatment. First line of treatment is risk reduction and smoking cessation, because you have to stop the etiological factors. Treatment 2 is a bronchodilator. Bronchodilators relieve what is our work? They relieve the bronchospasm and reduce the airway obstruction by allowing increased oxygen distribution and improving alveolar ventilation. So these medications, they are the core of management of COPD. And what we give a metered dose inhaler with the help of a nebulization, or it can be a pill, it can be liquid form, whichever. Now we come to something called a corticosteroid, and under bronchodilators, what are we particularly giving? We are giving B2 agonist, or with or without an anticholinergic, and along with that we give corticosteroid because they are effective when we want to stop the anti-inflammatory process. So they help in the exacerbation of COPD. And after that we give oxygen therapy, yes, of course, and always our targeted oxygen will be always from less than 92, from 90 to 92% in case of COPD. Next is antibiotics if there is a proven infection, and non-invasive mechanical ventilation. That is, if you see in case it improves the respiratory acidosis after doing ABG, if you find signs of less pH, that is, it means it is more acidic, so it will increase the pH, your mechanical ventilation. Non-invasive, we mean the BiPAP, and it reduces the PaCO2 respiratory rate also, and severity of the breathlessness also compared to the invasive ones. Now, there are some surgical procedures as well. Though it is very less common, like a bulectomy. Bulectomy, they are bullets, they are enlarged air spaces that do not contribute to ventilation, but they occupy space in the thorax. So, they areas are surgically excised. And lung volume reduction surgery, it involves basically removal of a portion of that diseased lung parenchyma, so that at least the rest of the part can be used as a functional space. Next is lung transplantation. We are talking also about the pulmonary rehabilitation. Under that, we have education, general exercise training, breathing retraining, outcome assessment, nutritional advice. What we should tell them to have small and frequent meal rather than having all the meals together, because the more metabolism, the more your lungs are working. Psychological support as well. What is our nurse's role, or what is the nursing management? We have assessment, monitor the respiratory rate, depth and effort, observe for the use of accessory muscles, check for the breath sounds. If you're hearing wheezing, you will hear wheezing, but if there is any lung infection, you will hear crackles in the lung base. See for hypoxemia, hypercapnia, evaluate your cough, sputum color, quantity, and assess the oxygen saturation. It should be typically between 88 to 92. ABG is also very important. Administer now under airway clearance, you have to administer oxygen, monitor your SpO2. At the same time, why are we stressing the one very important question? Why do we give low oxygen, or why do we want the patients to maintain low oxygen, acceptable oxygen in COPD? There's an important reason, because in COPD, low oxygen levels, hypoxemia, and low oxygen in the tissue, that is hypoxia, they are caused by damage to the lungs and airways, so which is restricting the airflow now, which will lead to the further damage. So oxygen therapy, we we always suggest to give, but we always try to maintain the optimal level of 88 to 90% only, or 92%, but not more than that, because when we give more oxygen, that does more harm than benefit. Why? Because we have to balance the risk of hypoxemia and hypercapnia. So this range will, you have to avoid hypoxemia. At the same time, you don't want the patient to be hypercapnic. That is, COPD patients, they have chronically elevated CO2 level, so their breathing is stimulated by low oxygen level rather than high CO2. So providing too much oxygen will suppress this drive, and that will lead to dangerous buildup of the CO2 in the blood called hypercapnia. So our basic role is to maintain that um, clinical balance between 88 to 92. Next is humidification if required, to prevent drying of the mucosa. Medications, as we told you, bronchodilators, corticosteroids, antibiotics, give rest before the meals and between meals, and give small frequent meals. High protein diet is required because of the healing process. And patient education, smoking cessation, risk reduction, psychological support, monitoring. Next, we come to the Nanda nursing diagnosis. This is very, very important. Under Nanda nursing diagnosis, the first one will be ineffective airway clearance related to the alveolar capillary membrane changes and ventilation perfusion imbalance, as evidenced by coughing, wheezing, restlessness, abnormal ABG values, confusion. Ineffective breathing pattern related to anxiety, fatigue, hyperinflammation of the lungs, or decreased lung compliance, as evidenced by shortness of breath with activity, or abnormal vital signs with activity or fatigue. And also we will see anxiety related to breathing, fear of suffocation, as evidenced by weight loss, increased heart rate, verbalization of fear. Risk for ineffective coping related to chronic illness, limited activity, impaired gas exchange related to alveolar capillary membrane changes, ventilation perfusion imbalance, as evidenced by use of accessory muscles, and imbalanced nutrition, less than body requirements related to increased energy, increased metabolic activity, and during breathing, labored breathing, poor appetite, and fatigue. We must also not forget there's risk for decreased cardiac output related to pulmonary vasculature resistance. Also to that we have the risk. So always we will start with the actual nursing diagnosis, that is ineffective airway clearance, number one. Number two, impaired gas exchange, ineffective breathing pattern, impaired nutrition, anxiety. Next we come to the risk. Under risk we have risk for ineffective coping, risk for decreased cardiac output, risk for infections or whatever. So this is all about COPD, and hope you have understood the nursing management, especially the pathophysiology. What is very important is the pathophysiology of COPD, the description, that is emphysema and chronic bronchitis, what is the difference between the both, and the nursing diagnosis. So stay tuned for more nursing topics, and hope this has been helpful for you. Do not forget to subscribe to my channel. Thank you so much. Bye bye. Take care.